Imagine waking up from this really quick, like 15-minute, minimally invasive procedure.
Right.
And your stress incontinence is supposedly cured. You put your clothes on, you go home that exact same day, and you're just, relieved.
Oh, absolutely.
But then a few hours later, you realize your body has suddenly forgotten how to do something you've done effortlessly since you were like a toddler. You feel this massive amount of pressure, you walk to the bathroom, and you are physically incapable of emptying your bladder.
Yeah, and it is a terrifying scenario. I mean, it places a massive burden of responsibility on a patient who is honestly still shaking off the anesthesia.
Yeah, exactly.
You're sent home to heal, which makes you the primary monitor of your own recovery. And translating those confusing signals your body is sending you becomes, well, critical, especially when the very thing designed to cure your leakage can temporarily cause this total biological roadblock.
Right. Which brings us to why we're here. Welcome to the deep dive. Today, we are opening up a highly specific but incredibly important stack of medical literature, clinical guidelines, and patient care protocols.
All very dense stuff, but so important.
Totally. And our mission today is focused entirely on you, the listener. If you or a loved one undergoes a procedure called urethral bulking to treat stress urinary incontinence, how do you know if your post-surgery symptoms are just a, normal temporary part of healing or a blaring red flag for acute urinary retention that requires immediate medical intervention?
Right, because the line can feel blurry.
Exactly. So we are going to map out the exact signs of this complication so you know exactly when to pick up the phone and call the doctor.
And just to ground this in the anatomy real quick, urethral bulking is a frontline treatment for stress urinary incontinence.
Which is the leaking when you sneeze, right?
Yes, exactly. That involuntary leakage of urine when you cough, laugh, sneeze, exercise, all of that. The procedure involves a clinician using a tiny camera, it's called a cystoscope, to navigate into the urethra, which is the tube carrying urine out of the bladder.
Got it.
And once they're inside, they inject a bulking agent directly into the mucosal walls of that tube.
Now, the sources we're looking at today spend a lot of time analyzing one specific agent called Bulkamid. And I really want to understand what is actually being injected into the body here.
It's actually really fascinating when you look at its chemical composition. Bulkamid is a soft hydrogel, and it's 97.5% water.
Wait, really? Almost all water?
Almost entirely water, and
Yeah.
just 2.5% polyacrylamide.
Okay, so what does that 2.5% actually do?
So the reason we care about that polyacrylamide is that it acts like microscopic scaffolding. It's an inert synthetic polymer.
Meaning the body doesn't fight it off.
Exactly. The human immune system generally ignores it. It doesn't trigger a massive inflammatory response or rejection. It just sits inside the tissue, holding onto that water, and it forms this network of fine fibers that cling to the urethral wall.
Wow, okay.
Yeah, it literally plumps up the tissue. It creates a physical cushion, like a seal, to stop the unwanted leakage.
And I can see why people choose this, because it avoids all the operating room drama.
Oh, for sure.
Like 10 to 15 minutes, no major incisions, no sutures. You can go back to non-strenuous activities almost immediately. But that mechanical fix brings us right to the core tension of this deep dive.
It does, because if we connect this to the bigger picture, the entire biological goal of this procedure is to manufacture resistance.
Right.
Stress incontinence means the urethra was too loose, right? The sphincter wasn't holding back the fluid. So by bulking up those mucosal walls, the clinician is intentionally narrowing the urethral lumen, the opening to increase resistance against the urine trying to escape.
Okay, let's unpack this for a second. It sounds like we are installing a speed bump on a steep hill to slow down runaway traffic.
That's a great way to look at it.
But occasionally that speed bump is built just a millimeter too high, or maybe the concrete is a little too fresh and swollen and it stops the cars entirely.
Exactly. If we stick with that speed bump idea, the mechanical resistance that protects you against stress leakage is the exact same resistance that can cause a total traffic jam in your urinary tract.
And there's a medical term for that, right?
Yes. The medical term for this roadblock is postoperative urinary retention, or POUR.
POUR.
Okay, POR. Now, I want to make sure we don't, terrify anyone away from what the clinical literature agrees is a very safe, effective procedure. The numbers on this are actually quite reassuring.
Context is absolutely vital here. The sources emphasize that while urinary retention is a really serious event, the rates after urethral bulking are remarkably low.
Like how low?
We're looking at an incidence rate ranging from just 1% to 10%, depending on the specific clinical study. Right. And you compare that to the traditional alternative, like mid-urethral sling surgeries.
Hmm.
I read those retention rates sit up around like 20%.
Yeah, much higher.
And the mechanics of fixing a sling are vastly different, right? Because a sling is a piece of surgical mesh acting like a hammock, which intentionally causes scar tissue to form around it for support.
Correct.
So if that is too tight, you are talking about a second surgery to literally cut through established scar tissue and loosen the tension.
Exactly, which is a big deal. But with bulking agents, the retention is highly transient. You aren't dealing with rigid scar tissue. You're dealing with a water-based gel and the natural inflammation from, a needle poke.
Just the swelling from the injection itself.
Right. The retention typically resolves in less than 24 to 48 hours as that localized swelling from the injection subsides. It rarely requires any sort of surgical revision.
That's good news.
It is. However, even temporary retention must be managed immediately or the downstream consequences are severe.
Okay, so since the physical goal of the surgery is to create that resistance, how do you, sitting on your couch at home, figure out the difference between normal post-op swelling and a dangerous obstruction?
That's the big question.
Let's map out the baseline first. What should a patient expect to feel when things are going perfectly well?
So, normal recovery for the first 24 to 48 hours is going to involve some localized discomfort. The clinical guides consistently note that patients will likely experience a burning or stinging sensation when urinating.
Okay, stinging,
Yeah. And you'll also likely see a small amount of blood in the urine.
which honestly, that makes biological sense. You just had a rigid cystoscope and a needle maneuvering inside a highly sensitive mucous membrane.
Exactly. It's an internal abrasion.
It's like going to the dentist for a deep cleaning. Your gums are going to bleed and throb for a day.
That's a perfect comparison.
Yeah.
You might even notice a tiny bit of clear gel passing in your urine if a small proportion of the bulking agent escaped the injection site before the tissue sealed around it.
Oh, wow. I didn't know that.
Yeah, all of this is standard localized trauma healing. The tissue is just bruised.
Here's where it gets really interesting, though. We need to define the absolute red flags of postoperative urinary retention. What are the signs that tell a patient to, stop waiting out the swelling and actually seek medical help?
The most severe red flag is absolute inability to void.
Like nothing at all.
Nothing. The clinical guides and patient resources are unanimous on this. If your bladder feels full, you feel the urge to go, and absolutely nothing comes out, you are in a medical emergency.
Okay.
The sources explicitly state to call 911 or go to your nearest emergency room if you cannot pass any urine. The plumbing is completely blocked and the internal pressure is building rapidly.
But the body rarely gives us a 100% clear-cut signal like that, right? A total blockage is obvious. But what about the insidious symptoms? I think dribbling means the plumbing is working. If fluid is coming out, my brain says, hey, I'm safe.
And that is one of the most dangerous misconceptions out there. Yes. Dribbling or leaking urine, combined with the feeling that you haven't actually emptied your bladder, is a classic presentation of retention. It's known as overflow incontinence.
Overflow incontinence. Okay, explain that.
So if we look at the physics of that dribbling, the bladder is basically a muscular balloon. When it reaches its absolute maximum volumetric stretch, the hydrostatic pressure inside the bladder eventually exceeds the pressure of the artificial speed bump we put in.
Oh, I see.
Right, so a tiny bit of urine is forced out simply because the container cannot hold another drop. It is a pressure valve failure, not a functioning urinary stream.
So the main reservoir remains critically overfilled.
Exactly.
Wow, that reframes things entirely. So a leak isn't a sign of flow, it's a sign of critical mass. What about having to push? Is that normal after surgery?
No, heavy straining to start a urine stream is a major red flag.
Really? Even just a little pushing?
Well, your detrusor muscle, that's the smooth muscle in the wall of the bladder, is designed to gently contract to push urine out. If you are having to bear down forcefully with your abdominal muscles just to force a few drops past the surgical site, the urethral resistance is far too high.
Okay, so pushing is bad. What about frequency? So frequent trips to the bathroom could actually be a sign that the bladder isn't emptying rather than a sign that it's working overtime.
Exactly. Urinating very frequently, but only producing an ounce or two at a time, means your body is desperately trying to relieve the internal pressure, but it can only manage tiny increments.
Which goes back to the overflow thing.
Right. If you were waking up constantly during the night to void small amounts, your bladder is retaining fluid.
Now, the literature also mentions severe bladder spasms. I want to translate that clinical term for everyone. What is happening mechanically in the pelvis? during a bladder spasm?
Okay, think of a car engine revving to the red line while the parking brake is fully engaged.
Oh, wow. Sounds painful.
It is. A bladder spasm happens when the detrusor muscle fires asynchronously and violently against a completely closed urethra.
Just slamming against a wall.
Yes, it feels like an intense, overwhelming, and deeply painful urge to urinate that just hits you like a wave. The muscle is essentially cramping as it tries to force fluid past a brick wall.
Ouch. Okay, so we have a really clear list of red flags here. Total inability to void, heavy straining, overflow dribbling, frequent tiny voids, severe pelvic pressure, and those violent engine revving spasms.
Right.
But there is a massive caveat in these sources that really stopped me in my tracks regarding how reliable our own symptoms actually are.
Ah, you're talking about the phenomenon of the silent full bladder.
Yes. This is crazy to me.
It really is. The sources document that more than 60% of patients who have undergone outpatient surgery do not report these painful symptoms, even if their bladder is dangerously overdistended.
More than half of the patients are walking around with a critically full organ and they feel nothing. How is that biologically possible?
It comes down to the pharmacology of the procedure. Urethral bulking is done under some form of anesthesia.
Right.
It might be local lidocaine, IV sedation with propofol, or even a general anesthetic. Plus, patients are usually administered pain medication, and these chemical agents interrupt the action potentials in your peripheral nervous system.
So they basically block the communication lines to the brain.
Exactly. Your bladder wall is lined with stretch receptors. Normally, when the bladder fills with about, say, 200 to 300 milliliters of urine, those receptors fire off a signal up the spinal cord to the brain saying, hey, we need a bathroom.
Makes sense.
But anesthesia and opioids create a roadblock in the spinal cord. Your bladder could be stretched to its absolute limit, holding 800 milliliters of urine. The stretch receptors are screaming, but the signal never reaches your conscious brain.
That is wild. But if the anesthesia makes me physically numb to my own internal alarms, what is my fail-safe? Like, if I can't trust my nervous system, how do I protect my kidneys and my bladder?
You protect yourself with a clock.
A clock?
Yeah. The post-procedure guidelines establish a strict chronological rule. You must monitor the time, and you should not go more than 6 to 7 hours without urinating post-surgery.
So what does this all mean in practice? It's just a rigid math problem.
It is a non-negotiable math problem. If your surgery wrapped up in the late afternoon, you go home and sleep, and it hits noon the next day without a normal void, you call the clinic immediately.
Even if you feel totally fine.
Even if you feel fantastic, do not wait for the localized anesthesia to wear off, because by the time the nerve block fades and the pain finally registers in your brain, the structural damage to your bladder wall has already begun.
Wow. Okay, let's follow this timeline. Say you hit that 7-hour mark, or maybe the anesthesia wore off quickly and you were trapped in those agonizing bladder spasms. You follow the protocol, you go back to the clinic or the ER. The medical team has to differentiate between acute retention and simple post-surgical hypersensitivity. And I was reading they tap on the stomach, which honestly feels like guessing. If my organs are on the line, I want an exact measurement. How do they actually see what's trapped in there?
Well, the tapping or percussion clinically is just the initial low-tech screening tool.
Okay, so it's the first step.
Right. The clinician is listening for acoustic resonance. An empty bowel sounds hollow, kind of like a drum. A bladder full of fluid produces a dense, dull thud.
Like knocking on a watermelon.
Yeah, exactly. And if that dull thud extends all the way up to your belly button, the acoustics suggest you are holding roughly 500 milliliters of trapped urine.
Wow.
If it goes past the belly button, it could be a liter. But you're right. To get the definitive scientific measurement, they conduct a post-void residual test, or PVR.
And this involves asking the patient to try and empty their bladder as much as humanly possible, and then measuring whatever fluid is stubbornly left behind.
Exactly. And the primary diagnostic tool for measuring that residual fluid is a bladder ultrasound. A clinician runs a non-invasive transducer wand over your lower abdomen, and high-frequency sound waves bounce off the fluid to create a real-time volumetric calculation right on a monitor.
Which, I mean, an ultrasound sounds ideal. It's painless, it's quick, and it doesn't involve inserting anything into a urethra that is already super traumatized.
It is ideal, mostly.
But the sources suggest ultrasound isn't always reliable. Why is that?
Ultrasounds have specific limitations based on physics. Adipose tissue or body fat diffracts and scatters high-frequency sound waves.
Oh, I see.
So for patients who are obese or patients with certain types of abdominal scarring, the ultrasound machine receives a scattered echo. This can result in phantom numbers, falsely elevating the reading, or failing to get a clear picture of the bladder entirely.
So if the ultrasound is bouncing off extra tissue and giving us phantom numbers, the medical team has to rely on something physical. They have to actually, go in,
Yes, they rely on urethral catheterization.
which nobody wants.
Nobody wants it. But a nurse will lubricate a thin, flexible tube and slide it directly into the urethra, navigating past the newly injected bulking agent to physically drain the trapped urine into a collection bag.
While that sounds incredibly uncomfortable, the relief of dropping that internal pressure must be instantaneous.
Oh, it's immediate relief.
Plus, it gives the clinical team an undeniable exact measurement right down to the milliliter.
Yep.
So what are the numbers they're looking for?
The clinical thresholds are very clear once that fluid is measured. A post-void residual volume greater than 200 to 300 milliliters confirms clinically significant retention.
Okay, 200 to 300.
And if that volume is between 350 and 1,000 milliliters, the patient is in severe high-risk retention.
So we have a confirmed traffic jam. The fluid is backing up, the pressure is critical, the intervention phase begins. My immediate fear reading this was the logistics of shoving a plastic tube through the exact spot where a surgeon just meticulously placed a delicate hydrogel speed bump.
Yeah, it's a huge concern.
How do they drain the bladder without ruining the surgery you just paid for?
The clinical guidelines mandate a highly cautious approach to protect the bulkamid. The managing clinician will typically order an indwelling Foley catheter, which stays in overnight, or they will instruct the patient on intermittent self-catheterization, which means inserting a tube 4 times a day.
Okay.
But to protect the surgical site, they use a remarkably small catheter, specifically an 8 to 10 French size.
And the French scale measures the outer diameter of the tube, right? So an 8 French is less than 3 millimeters wide. That is tiny.
It is incredibly thin, and if they use an indwelling Foley catheter, they have to inflate a small balloon at the tip once it's inside the bladder to prevent the tube from sliding out.
Right, to anchor it.
Exactly. Now, standard catheter balloons are inflated with 10 to 30 milliliters of water. The protocol here dictates inflating that balloon with a maximum of just 5 milliliters.
Why does the balloon size matter so much?
It's all about the anatomy of the bladder neck. A large, heavy balloon resting at the base of the bladder puts constant downward physical pressure on the precise mucosal tissue where the bulking gel was just injected.
Ah, I get it. So you'd squish the gel.
Exactly. A tiny 5 milliliter balloon minimizes that localized pressure, preventing the hydrogel from being displaced or compressed while the tissue heals.
Okay, so the mechanical blockage is bypassed with the Pliny catheter.
Yeah.
But there's also a pharmaceutical intervention mentioned in the sources to help speed up the plumbing repair.
Yes. The clinical team will often initiate a selective alpha blockade medication. These are pharmaceutical drugs like tamsulosin or alphazocin.
Let's look at what an alpha blocker actually does on a cellular level. Like, how does a pill open up a blocked tube?
Alpha-1 adrenergic receptors heavily populate the smooth muscle at the base of your bladder and throughout the urethra.
Okay.
When neurotransmitters bind to those receptors, the muscle constricts. Alpha blockers actively prevent that binding process. They force the smooth muscle to relax.
Okay, so they just chemically chill everything out.
Basically, yeah. By chemically relaxing the internal environment, they reduce the baseline resistance, essentially widening the funnel and making it easier for the bladder to push urine past the bulking agent.
Got it. So the catheter drains the dangerous backup, the medication relaxes the smooth muscle, and the localized surgical swelling naturally subsides over time. How long does a patient usually rely on this mechanical override?
The standard timeline is just 1 to 3 days.
Well, that's not bad at all.
No, it's very quick. After that brief resting period, the nursing staff performs a trial without catheter, or a TWOC.
The TWOC, love the acronym.
Yeah. They remove the tube entirely, allow the bladder to fill naturally, and observe if autonomous voiding function has returned.
And how do they confirm that?
If the patient can urinate and a follow-up ultrasound shows a residual volume back under 200 milliliters, the trial is a success. If the residual remains dangerously high, the catheter goes back in, and the patient's care is escalated to outpatient urology.
It sounds like a major hassle, going back to the clinic and dealing with catheters. But the sources are stark about the physiological damage of ignoring this. Untreated acute retention isn't just uncomfortable, it is destructive.
Highly destructive. In the acute phase, severe retention triggers intense pain, vomiting, dangerous spikes in blood pressure, and cardiac arrhythmias due to the massive systemic stress response.
Wow.
But the long-term consequences are permanent.
Because you're stretching a muscle too far for too long.
Exactly. When the bladder is subjected to severe, prolonged overdistension, stretching out like an overinflated balloon for hours or days, the detrusor muscle fibers suffer microtrauma.
They just tear.
They physically lose their elasticity. If you wait too long to seek intervention, you might successfully cure your stress incontinence with the bulking agent, but you've permanently destroyed your bladder's mechanical ability to contract and empty itself. The pump is broken.
That is terrifying. So what this all boils down to is really a shift in perspective. Needing a catheter after urethral bulking does not mean the surgery failed.
Not at all.
It isn't a botched procedure. It is a temporary protective safety valve. It protects your kidneys and your detrusor muscle while the initial trauma of the procedure settles down. The speed bump works. The concrete just needs 48 hours to dry.
That is the exact right way to look at it. It is a critical bridge to a successful long-term recovery.
Okay, let's solidify the core takeaways for anyone navigating this procedure. Number one, understand the baseline. A little burning and localized spotting is normal tissue trauma.
Right.
Number two, memorize the red flags. Absolute inability to void, overflow dribbling while feeling full, extreme pelvic pressure, and severe spasms mean the resistance is too high.
Absolutely.
And number three, never trust your own nervous system if you've had anesthesia or pain medication. Live by the 6 to 7 hour clock.
Which raises an important question regarding the underlying cause of this retention, and it brings us to a really fascinating twist in the recent medical research.
You are looking at the GRI study. I loved this part.
Yes. We have spent this entire discussion framing urinary retention as a localized mechanical plumbing problem. The hydrogel goes in, the lumen gets narrow, the fluid gets blocked.
Right.
But emerging research highlights a neuromuscular component. Many women who suffer from stress incontinence also exhibit underlying neuromuscular impairments. Their central nervous system and their pelvis floor muscles have faulty communication pathways.
So we aren't just talking about a physical speed bump anymore. We are talking about like a software glitch in the nervous system itself.
Exactly. The theory centers around what they call the guarding reflex. The pelvic floor muscles, specifically the levator ani, act as a supportive sling.
Okay.
The physical trauma of the cystoscope and the needle injection triggers a sympathetic nervous system reflex, a nociceptive withdrawal reflex. The body senses pain and tries to pull away from it, but obviously you cannot physically withdraw your own urethra.
Right, you can't run away from a needle that's inside you. So the muscles do the only thing they can do. They clamp down in an extreme sustained spasm. They're trying to build an armor wall around the injured tissue.
Precisely. By heavily guarding the injured area, the pelvic floor inadvertently clamps the urethra completely shut, causing the retention.
Oh, wow. So it's not even the gel blocking it. It's your own muscles panicking.
Often, yes. And this led to a new clinical concept called guarding reflex inhibition training, or GRIT. The protocol suggests that if we use specialized physical therapy to train patients before surgery to consciously recognize and relax this involuntary guarding reflex, we can dramatically reduce the rates of postoperative retention.
That is a remarkable evolution in patient care. The future of preventing post-surgical complications isn't just about selecting the perfect 8 French catheter or perfecting the water-to-polymer ratio of the bulking gel. It's about training the patient's brain and nervous system before the needle ever touches the tissue.
It proves that we are highly complex, interconnected biological systems, not just a series of isolated pipes.
I want you to mull that over. The idea that to fix a physical roadblock in the body, you might actually need to reprogram the traffic control center in your mind. Thank you so much for joining us on this deep dive. Stay curious, listen to the signals your body is sending you, but remember, when the anesthesia is flowing, your brain will lie to you. Always trust the clock.